Good afternoon, everybody, and welcome to Ask the Doctor number 5, a conversation with Dr. Alexander Penteliat. This will be a recorded webinar, and the recording will be made available on our website in the next few days, and a link will be provided in a follow-up email. My name is Joanna Teters, and I'm the Community Outreach and Resource Manager with CurePSP, and I'm thrilled to be here today. Please note that we are using Zoom. Zoom is not a confidential platform, and it is not HIPAA compliant. Any disclosure of personal information may be revealed to others in the group, including those not logged into the program. We expect everyone to respect confidentiality of who attends and what is shared. By choosing to attend the meeting, you are consenting to participation. This is also being streamed on Facebook Live. A quick Zoom overview. Please type your questions in the Q&A function of the webinar. And if you have the same question that's in the Q&A, please like it to avoid duplicates. Most of the questions that we will be answering have been previously submitted to Dr. Penteliat. And also please use the chat box to interact with each other, but please do not reveal personal medical info. Thank you so much for your cooperation. It is my pleasure to have Dr. Alexander Penteliat here with us today. Dr. Penteliat is a leading expert in progressive supranuclear palsy, Parkinson's disease, corticobasal degeneration, multiple system atrophy, and related movement disorders. He is currently the assistant professor of neurology at Johns Hopkins University in Baltimore, Maryland, and the director of the Atypical Parkinsonism Center. Dr. Penteliat is the author of the paper, or an author of the paper, Music Therapy and Music-Based Interventions for Movement Disorders, and is an accomplished violinist who believes that music can be an integral part of the treating illness and can be incorporated into therapies to improve the quality of life for patients. To get our talk on music and movement disorders started, I'm going to play a video clip called The Healing Power of Music, and it's a brief look into the Johns Hopkins Center for Music and Medicine. We want to also say a big thank you to Power Over Parkinson's for partnering with us here today. I'm going to quickly share my screen and get this video going. It didn't go through. Oh, hold on one moment. Let's see here, share screen, share. Oh, it's not letting me share my sound, so let's try this one more time. Share.
As long as humanity has been around. Music has been an integral part of the human experience as long as humanity has been around. And I think it's intuitively been felt for a long time that music can have healing properties. This is, I think, pretty safe to say, certainly one of the biggest, if not the biggest, choir of persons with Parkinson's disease in the world. The areas for being able to perceive music and also to make music have overlap. We now have the tools to be able to answer more specific questions about how it is that music affects the brain and other body systems. And therefore, we have the incredible opportunity to tailor music, use precision music medicine, if you will, for the purposes of healing. I'm Alex Penteliat. I'm an assistant professor of neurology at the Johns Hopkins University School of Medicine, and it's been an absolute thrill for me to co-found and co-direct the Johns Hopkins Center for Music and Medicine. Music is what I would be doing if I weren't doing medicine. I decided that, in a sense, medicine was an easier way out than the classical. Sometimes. The vision that we have for our Center for Music and Medicine is to bring music and medicine together by making music an integral part of treating illness
This collaboration consists of research activities, clinical care, and education and outreach, spread out among a wide range of different people from different aspects of the healthcare system and the School of Medicine faculty, as well as Peabody musicians and Peabody faculty.
There is a lot of research on music and neurological disease, such as Parkinson's disease, Alzheimer's disease, epilepsy, stroke, rehabilitation.
This is not a new idea. In shamanistic cultures, if you can see the shamanistic healers use music. It's part of their regulars, their aspirin. Now we can objectively measure some of these impacts that music has on people.
Part of what we're trying to do here is produce rigorous research at the level of Johns Hopkins standards to further the field.
We know music activates a host of different areas of the brain. In fact, some have said that listening to music, making music, activates more parts of the brain than just about any other human activity, which of course is what makes it so complicated to study, if everything is getting activated at the same time.
It's a whole body experience with sensory motor demands. It's a good diet for people suffering from neurodegenerative diseases if they engage in actively making music.
It's fascinating and very powerful to think that something that's been floating around in our environment forever, to think that this natural, omnipresent human activity actually has demonstrable benefit as treatment and medicine.
At this time, I'd like to welcome Dr. Alex Pantelliat. Alex, thank you so much for being here with us today. It's truly a pleasure to have you be our fifth Ask the Doctor webinar speaker, and thank you for putting together such a wonderful presentation. I'm really looking forward to hearing more about music and movement disorders.
Thank you so much, Joanna, and CurePSP for inviting me today. It is my pleasure to give you a taste of what music-based and rhythm-based interventions may be able to do for people suffering from diseases like Parkinson's disease, PSP, and other Parkinsonian disorders. Go ahead and share my screen. Everyone can see my screen?
Yes, we can.
Fantastic. We'll get right to it. So as you just saw in the introductory video, I'm here in my role as the director of the Johns Hopkins Atypical Parkinsonism Center, but also as the co-director of the Johns Hopkins Center for Music and Medicine. Our vision can be summarized as the motto, music as medicine and medicine for musicians. So our goal is to bring music and medicine together by making music and rhythm an integral part of treating illness and by improving the health of musicians. So briefly, today I want to give you, again, just a taste of different types of music and rhythm-based interventions available with at least some evidence behind them. I want to give you a sense of how music and rhythm may work in the central nervous system to produce benefit, and give you some examples of studies done at our center over the last several years. And I always love to begin with this quote from Shakespeare and Richard II. Music do I hear? Ha, ha, keep time. How sour sweet music is when time is broke and no proportion kept. To me, this intimately links melody and rhythm together. Really that's kind of behind the concept of music and rhythm-based interventions. If you divorce one from the other, it is likely that the effect may be less than the combination of the two. So now we're going to delve in to this busy slide, which demonstrates both the problem and the challenge and the promise of what music can do. What you have here in different colored circles are what studies have shown about the effect that music could have on the brain. So, of course, we won't go into this in detail. These are cutaways of the brain. On the left-hand side, you see the right hemisphere, right half of the brain, and then you have a cutaway of the left hemisphere on the right-hand side. And so, of course, as you might expect, listening to music as well as producing music, that's either playing an instrument or singing, activates the basic auditory pathway, which is common for hearing any sounds. But far beyond that, it activates a music-specific set of networks. So higher order musical features, that's in the kind of turquoise color here, are perceived in the planum temporale, for instance, which is an area in the temporal lobe that is fairly specific for processing of melody and pitch. Attention and working memory in the frontal lobes of the brain are intimately engaged by both listening to music and making music. In other words, we need to focus and keep track of the music over time. The episodic memory network, this of course is relevant to Alzheimer's disease as well as a number of other dementias, to be able to recognize what music you're hearing and recall associated, often autobiographical memories. In darker blue, and this is really relevant for today's talk, we know that music and rhythm can engage the motor movement-related network, playing, singing, moving to the beat of music. And then very importantly, in orange areas, mostly on the right-hand side, more towards the middle of the brain, if you will, that's the network processing reward and emotion. Music evoke emotions and pleasurable experiences can be very, very powerful. And this is a key to the motivating power of music that could help us exercise and do and be able to sustain a lot of different activities. For those who are curious, I have here underlined whether both sides of the brain are involved in music processing and to what extent. Most processes related to melody are actually on both sides of the brain. So you're activating both hemispheres, both halves of your brain by listening to music and making music. The exception is pitch and melody processing. That tends to be mostly on the right side of the brain. So without further ado, let's delve into some examples of neurologic music therapy or music-based interventions. Here I include a quote from a leader in the field, Michael Tout, who's currently at the University of Toronto, and that is, the brain that engages in music is changed by this engagement. What this really is talking about is the concept of neuroplasticity. Up until about 10, 15 years ago, it was thought that in the central nervous system, once damage is done to the neurons, the brain cells, then it's irreversible. Well, it is true to a great extent, but we now know that there are parts of the brain that continue to generate new cells, new neurons, well into somebody's 50s, 60s, 70s, and beyond. And music and rhythm-based interventions can generate activity that will be called neuroplasticity, changes, measurable changes in the brain. We know that, as I already pointed out in the prior slide, music can stimulate a number of areas of the brain, and potentially, this is the key, potentially this kind of stimulation may be generalized and transferred to non-musical applications. For example, being able to have better walking and balance. We know that musical activity can be used to activate brain areas that are either not affected or less affected by certain neurological diseases, possibly allowing us to bypass pathways that have been affected by disease. But of course, we need to do more research, as all the researchers say. Here, I want to summarize this hypothesis put forward nearly 10 years ago by Dr. Anirudh Patel, which really pertains to how music and speech overlap. They overlap in a number of areas, and this is a nice acronym that kind of underscores some of the ideas behind why music-based interventions can engage the brain and lead to translation outside of the musical environment. So O stands for overlap in this opera acronym. There's actual anatomical overlap in the brain networks that process sound for both music and speech. I already alluded to this in the temporal lobe before. P stands for precision. Music, compared to speech, generally places a higher demand on these networks for processing sound compared to speech. And this is basically referring to the precision, the timing of being able to follow along with music, and even more so when you're trying to sing to a beat or play a musical instrument. E stands for emotion. Musical activities that engage some of these networks can elicit very strong positive emotions. I would add here that, of course, one size does not fit all when it comes to music and rhythm-based interventions. So we need to do further work to be able to develop precision music medicine. But we know that assuming that a song is being played that is enjoyable to a patient, that could elicit very strong activation in areas of the brain processing pleasure. For example, the nucleus accumbens. On the other hand, if it's a song that we don't like, very strong emotion in negative emotion can be elicited as well. R stands for repetition. This is really important in terms of this idea of we don't use it, we lose it, right? That's true for getting older in general, and it's true exponentially for people suffering from Parkinson's disease, PSP, and related disorders. So the musical activities that engage networks are often repeated. They need to be repeated in order to sustain benefit. And finally, A stands for attention. Musical activities engaging the attentional networks are associated with being able to focus for longer periods of time and more effectively. So what are some of the specific types of music-based interventions that are available? We don't have time in a brief talk today to go into all of these, but I will highlight a few of them. Specifically, and this is something that everyone can do, music-assisted relaxation. We know that stress can exacerbate symptoms of Parkinson's disease and PSP and other related disorders. Generally speaking, if you're asking me to write you a prescription for what to listen to and to be able to relax, I would recommend calming music at a rhythm of 50 to 60 beats per minute, which is approximating normal resting heart rate, our pulse rate. Instrumental music as opposed to sung music. So words could be distracting and they could have a lot of emotional valence in and of themselves. So instrumental music to be safer. Generally lower frequency, in other words, not too high pitched, and without too much variation with respect to loudness, to the pitches, or to rhythm. Both patients and care partners often report decreased stress and other symptom improvement during music listening. But one challenge has been how to harness that improvement to make it last beyond the actual period of listening to music. So now, I know we have a number of listeners with Parkinson's disease whose lives have been affected by PD. Because most of the interventions using music and rhythm have been tested, trialed so far in Parkinson's disease as opposed to the atypical Parkinsonian disorders, I thought it would be useful to include this slide. We know that Parkinson's disease is the second most common disorder after neurodegenerative disorder after Alzheimer's disease. This is really extremely conservative estimate. Depending on how we look at it, there are likely to be more than 1.5 million cases in the United States of Parkinson's disease already, but many people don't know about it. The 4 cardinal signs of Parkinson's disease, this is another mnemonic or acronym we teach the medical students. T stands for tremor, shaking of any body part. R stands for rigidity, which is muscle stiffness as opposed to joint stiffness. A stands for akinesia, or more appropriately bradykinesia, a loss of fine motor control and coordination and a slowing of rapid movements of the hands and feet. And P, which is highlighted, bolded here, stands for postural instability. This relates to difficulties with walking and balance that could lead to an increased risk of falls. Now, for those who are listening who are affected by atypical Parkinsonian disorders, to at least some extent, pretty much all of these cardinal Parkinsonian features or signs are seen in people with atypical Parkinsonian disorders as well. And in fact, Some of these, specifically postural instability, can be seen much earlier in the disease course compared to Parkinson's disease, and can be much more severe. So really, it's logical to have that be the object of research focus. So now let me ask, how might music and rhythm work in Parkinsonian disorders? Well, therapeutic music performance, playing in order to get benefit beyond the enjoyment of playing, or singing, can be used to improve both gross and fine motor skills through this idea of rhythmic entrainment. In other words, getting a rhythm into the brain that the brain is then able to follow on its own, generating an expectation of what beat is going to come next. One real world example of this, which is, if you think about it, pretty miraculous. If you've been to a pop, rock concert or a hip hop performance in a huge arena, sometimes the performer asks the fans to start clapping along. And even if there are thousands of people in the audience, it takes but a few seconds for people to sync up. This is kind of a good illustration of what I mean by rhythmic entrainment. If we didn't have a brain that was attuned and able to generate this internal sense of rhythmic, time-related pattern, we wouldn't be able to start clapping along together with thousands of others. So again, the idea here is to either strengthen the faulty pathways in the central nervous system that are affected by ongoing neurodegenerative processes, or perhaps get around them altogether. So this is just a photo illustration of what I'm trying to say. The yellow dots with arrowheads refer to the known internally generated movement pathways. Some of these same areas that are just that were illustrated in a prior slide at the beginning are now linked up. We know that there are connections between these areas in the brain. Again, we're looking at the side view, a sagittal cutaway of the brain kind of towards the middle. So the cerebellum, the basal ganglia, the deep centers of the brain that we know are affected by degeneration in Parkinson's disease and PSP and related disorders, these are key areas that are involved in planning and actually carrying out the impulse to do a voluntary movement. Then from those deep areas, the arrows go up to the supplementary motor area, pre-supplementary motor area, supplementary motor area, and finally what's circled in a big circle in red is M1, which is the primary motor cortex. The signal that's internally generated needs to end up at that level in the motor cortex in order to actually send the impulse down to the spinal cord and then to the muscles to make a movement. So is there another way to get there if this internally generated movement pathway is impaired, is interrupted, the highways being impacted by loss of millions of brain cells as a result of these degenerative disorders? Well, perhaps the answer is yes. This is one of the hypotheses, but if you look at the broken white arrows, there is another pathway for externally cued movement. What I mean is hearing a sound, hearing a melody, hearing a rhythm can actually potentially bypass this internally cued movement and going through the parietal cortex, so different lobe, different part of the brain, end up at the same area where we have to end up in order to actually carry out the impulse for any movement. That's the primary motor cortex. So again, this idea of bypassing the faulty pathway for internally generated movement, which we know is affected in all of the Parkinsonian disorders. So how do we really define rhythmic entrainment? I gave you an example, but let's be a little more formal. It involves the patterning of body processes or movements, such as tapping your foot, clapping your hands to the rhythm of music. There's even this idea of perhaps that this was serving an evolutionary purpose to achieve altered consciousness, where people feel reduced fear and pain, they lose their sense of individuality, and are united in a shared collective identity. Perhaps this could have been crucial for our ancestors' survival against predators once our ancestors descended from the trees and became terrestrial, ground dwellers. But of course, this is not something we could prove for sure. This is a hypothesized evolutionary purpose. So now let's talk about some of the ways that rhythmic entrainment may be able to help. Well, perhaps it could accelerate normal motor learning of movements. This, again, is the idea of experience-dependent neuroplasticity. The brain that engages in music is changed by this engagement. There's some evidence that as little as 15 months of musical training, playing an instrument or singing, may be sufficient to induce noticeable changes using, for example, functional magnetic resonance imaging, that you could actually see changes in the brain. Maybe the type of motor learning that rhythmic entrainment could induce is different. Simply listening to music can already change a person's responses to other sounds when they are presented once you've been primed by music. Being able to acquire new temporal skills, that means time-related skills. Parkinson's disease patients show the ability to have finer perceptual skills, I mean time perception, rhythm perception, after they get a cue-assisted gait training with a metronome. And this is something we'll talk about briefly some more in a moment. Enhancing motivation. I already alluded to the fact that peak musical experiences can be associated with activation of areas that are affected in Parkinson's disease, PSP, and related disorders, and in fact may induce endogenous, our own release of dopamine. Dopamine is what's missing in Parkinson's disease and these related Parkinsonian disorders. And if we could find a way to induce release of what's left of remaining dopamine stores, that could be helpful. This has been proposed as a mechanism of how enjoyable exercise can be helpful for Parkinson's disease and related disorders. And finally, last but not least, again, I want to say a word about attention. Executive functioning using the frontal lobes is absolutely crucial in order to accomplish tasks in Parkinson's disease, PSP, and related disorders that previously were automatic. In other words, to be able to walk as before, even in early Parkinson's disease, a patient needs to activate the frontal lobes in order to keep attention on their walking pattern and make sure that balance is remaining within normal range. So being able to activate the frontal lobes, the attention network, can actually help this process. So that's about all I'll say about this part. So now, what is this type of music therapy that involves rhythmic entrainment? It's called rhythmic auditory stimulation. It was described in the 1970s, so this is not new, and it's typically used for rehabilitation, improving walking and balance. Rhythm is used as an external timekeeper, and the sound cue is provided by a metronome or recorded or even live music that has a strong rhythm. So for those interested, there are free applications for both the Android and the system and the iPhone, some of which I use working together with physical therapists in order to use as a metronome device, a free metronome application that you could use at home. So the idea is to anticipate the next step as you're stepping to the next beat. And another approach is to actually count down 1, 2, 1, 2 as one marches, or singing along. All of these have been tried in different studies involving patients with Parkinson's disease-related disorders. So what can it help with? Well, it could help people with start hesitation, very common problem in advanced Parkinson's disease as well as PSP. Gait freezing, I know we have a question coming up I will get to about how to overcome freezing. This is what we're talking about here. Gait stability, with one study last year in Parkinson's disease showing that 30 minutes of walking to a metronome 5 days a week at home may actually reduce falls in people with Parkinson's disease. It could improve walking speed, the length of steps, stride length, and coordination of the steps. For freezers specifically, it's been suggested that slower sound cues may help with this problem of both freezing and also festination, which involves increasingly smaller and rapid steps until a freeze, in other words, feet get stuck completely to the ground, a freeze is reached, and that often can lead to a fall. So the idea is to allow more time for patients to target longer strides. Same idea, as many of you recognize, I'm sure, behind big therapy, big physical therapy for rehabilitation. So this is just a picture showing, what goes wrong in people with Parkinsonian disorders. The stride length, the length between steps becomes shorter. Steps become more asymmetrical, and there's something called a high cadence, which is a measure of variability between the timing of the steps. And so rhythmic auditory stimulation in different studies has been shown to lengthen stride length, decrease the cadence, and lead to more symmetrical steps. Now I'm going to, before I just talk about music therapy for voice and switch gears, I just want to say a word about a study that we are preparing for publication now. So I didn't have an actual slide there for this reason, but in our clinic for atypical Parkinsonian disorders, over the last 4 years or so, we've actually used metronome through an iPhone application, working with our physical therapists in patients with all 4 major neurodegenerative Parkinsonian disorders. So it was mostly patients with PSP, but also patients with multiple system atrophy, corticobasal syndrome, and dementia with Lewy bodies. And all in all, what I could share with you so far, we did find that in patients with atypical Parkinsonism, not just with PD, in the short term, during a in-clinic session, we were able to achieve some of these same improvements that are summarized here, particularly the cadence, the variability of the steps linked up successfully due to metronome cueing. And then when we repeated the test without rhythm, about 10 minutes after the rhythmic auditory stimulation component, there was a carryover effect. In other words, the benefit seemed to be conserved. So we're preparing this for publication, but I just wanted to say a word about this. And this improvement was seen in patients with PSP to a greater extent than in other groups. And patients with dementia with Lewy bodies who were significantly more impaired from a cognitive standpoint and likely had more trouble following the directions from the metronome and from the physical therapist, they actually had a worsening in their gait pattern. Again, underscoring the point that one size does not fit all when it comes to these music and rhythm-based interventions. So what about music therapy for voice? Well, therapeutic singing can help us focus on deeper breathing to counteract the soft or fading volume and monotone voice to improve understandability. This is a big problem in Parkinson's disease, PSP, and related disorders. With practice, music therapy for voice can help with speech initiation as well. I'll skip this in the interest of time. So now I'll just tell you about a few studies, starting with an early study in 2016 that we undertook to improve voice quality and quality of life, as well as motor symptoms in people with Parkinson's disease. So we randomly assigned participants with Parkinson's disease to either sing in a choir together weekly or have a weekly facilitated Parkinson's disease support group. So the clip that you saw at the beginning was actually that Parkinsonics choir, as we called it. I am happy to say it's going strong, and it's continued via Zoom during the pandemic. After 12 weeks of either singing or the support group, we crossed the participants over. So that way everybody over the course of 24 weeks was exposed to 12 weeks of singing and 12 weeks of a support group. We looked at a number of relevant outcomes, and the people who were assessing the outcomes were not aware of which group at that time the participant was in. So over 80% of participants completed the study, and this was a 30-week study. So that indicates it's feasible to carry out. And we found overall, for the entire 26 participants, we found significant improvements from baseline in average loudness. We measured this with a decibel meter. When it came to describing a picture at 24 weeks, and also improved minimal reading volumes at both 24 weeks and 6 weeks after all of these interventions were completed. We also noticed increased minimal voice loudness on reading a standard paragraph called the rainbow passage, also sustained for at least 6 weeks after everything was completed. Interestingly, we were surprised to learn that the motor scale of the Parkinson's disease rating scale improved as well, regardless of whether participants sang first or sang second. So we concluded that weekly group singing is a feasible intervention that may improve some aspects of conversational, real-world voice volume in Parkinson's disease. And some of these improvements were sustained at least 6 weeks after the end of the study. So as I mentioned, the Parkinsonics program has continued weekly, previously at Govans Presbyterian Church in Baltimore, and now through until a couple of weeks ago through Zoom. They're now on hiatus until September. Our Hopkins Parkinson's Disease and Movement Disorder Center is funding the study, and we are actively planning follow-up assessments of voice, movement-related function, and quality of life. Now, I want to say a few words about a different, more recent study that we completed called Guitar PD. This was in close partnership with the Peabody Institute, which is a school of music at Johns Hopkins. It was supported by the Brain Science Institute as well, which is a philanthropic foundation within Hopkins. And we wanted to look at quality of life, hand movements, both fine and gross motor movements, cognitive function, mood, as well as anxiety, as a consequence of 6 weeks of undergoing guitar classes. Here again, we had two groups of patients with Parkinson's disease, and one group was randomly assigned to start guitar classes weekly for 6 weeks right away, and the other group waited for 6 weeks. And we were assessing outcomes every 6 weeks until the end of the study. So across all participants, the overall Parkinson's disease quality of life summary index scores did improve from baseline to week 12, which is the completion of the guitar classes for everyone, and it remained improved 6 weeks after the end of the interventions. This appeared to be clinically significant, but wasn't statistically significant. The Beck Depression Inventory score, so mood, tended toward improvement after 6 weeks of guitar lessons, and apathy measures, this is a sub-score of a scale that we use, also tended to improve after 12 weeks. We also found that total scores, again, in that Parkinson's disease rating scale, the motor scores, improved at 12 weeks and remain improved at 18 weeks as well. So the last study I'll tell you involves drumming. We know that it's long been part of traditional healing rituals in many cultures across the world. And when I was still in training prior to my coming to Hopkins, I was at the University of Pennsylvania in Philadelphia. A group of patients with Parkinson's disease had a single West African drum circle class as part of their support group for 45 minutes. And they came to us and were saying things like, I feel like my freezing is better, my walking and balance is better, after just sitting around in a drum circle and beating a drum, which was really surprising. And so led me to ask, can drumming improve well-being and motor function in PD? So we designed a pilot small study of two groups of people with Parkinson's disease, 10 of them assigned to the drumming and 10 of them who pursued their usual activity as controls. That could include physical therapy, occupational therapy, for instance. And there were twice a week drumming classes for the drummers. So a total of 12 classes over 6 weeks. And we assessed people, again, every 6 weeks from beginning of the study at 6 weeks, which is the end of drumming, and then 12 weeks, 6 weeks later. 8 out of 10 people in the drumming group completed the study. And this is a recording I want to share with you from the middle of the 6 week drumming period. I think you get the idea, and I wanted to particularly direct your attention to the gentleman sitting to the immediate left of our charismatic drumming instructor. Notice the swaying. So what were our results? Well, again, we looked at quality of life first and foremost, and we found that the summary index score for the Parkinson's disease quality of life questionnaire actually improved, statistically and clinically significantly improved after just 6 weeks of drumming. And when we reassessed people 6 weeks after the drumming was over, which is this panel over here, we saw that they had worsened again, and it was indistinguishable statistically from the baseline quality of life rating. And of course, for the control group, patients with Parkinson's disease who pursued their usual care over the same time frame, there were no significant changes in their quality of life, as you might expect. Now, I just want to share with you a few reflections of participants in that study, which we called Drum PD. Drumming forced you to focus on the rhythm that you were playing without becoming distracted by the music of others. Notice, attention, just to link it to the themes that I introduced earlier. Another participant, I suspect you know who I'm talking about if you looked at the video, mentioned, talking about putting my dyskinesias to work. Another said, it doesn't get any better. It's like singing with a choir or harmonizing with a small group. I thought it was an interesting parallel. Again, blending the idea of melody and rhythm in my mind. And finally, one patient said, I found that I was able to coordinate my hands even when I was off medication, which was really interesting. So we can conclude that 6 weeks of twice-a-week West African Drum Circle classes significantly improved self-reported quality of life in patients with Parkinson's disease, but this improvement waned within 6 weeks of finishing the classes, which suggests that like other non-pharmacological interventions, behavioral interventions, if you will, it's necessary to sustain them in order to retain the benefit. We also saw that there was a trend towards improvement in mood, but this was not something that the study was really large enough to say with any certainty. Now, before I conclude, I just want to say a few words about exciting things that are recently happening in the world at large that pertain to our topic. British Health Secretary Matt Hancock, I believe he's still in his current position, in 2018 already proposed to enable UK doctors to prescribe therapeutic art or hobby-based treatments for illnesses that include dementia. The idea is to have this implemented all across the United Kingdom by 2023. And it's this exciting concept called social prescribing. A similar, more focused campaign was launched in the fall of 2018 in Montreal. And even more recently, the state of Massachusetts, its Cultural Council, launched a pilot social prescribing program as well. This is something that I would look forward to as being implemented across the United States. Another very exciting recent development is this NIH Kennedy Center, which is in Washington, DC, collaboration. There was a workshop on music in the brain back in 2017 called Finding Harmony, and it led to the Sound Health Initiative, which is an ongoing, very exciting development. And currently, during the time of coronavirus, there are webinars monthly that are hosted by Renee Fleming, who's a cultural outreach director for the Kennedy Center. It's called Music in the Mind. I recommend you guys look it up. There was also a music and health funding opportunity last year, which led, and this is really exciting, to $20 million for 15 different studies pertaining to the basic and clinical applications of music to healthcare. So to conclude, music and rhythm-based interventions, I hope I have given you a taste that they have emerging evidence of benefit for Parkinsonian disorders. The quality of the evidence, the way the studies have been designed, such as the size of the study, the duration of the study, the use of controls, had been the limiting factor, but has been improving in the field. And this is very exciting. But of course, we do have a pervasive remaining need to clarify the mechanisms of how specific music and rhythm-based interventions can help specific patients. At this point, I want to thank you very much, and I'm happy to answer any questions in the remaining time.
Thank you so much, Alex. That's a wonderful presentation, really insightful, and we really appreciate you taking the time to speak on this topic for all your work at Johns Hopkins. We do have a few more minutes to answer some questions. We received a wonderful amount of questions via registration for this webinar. So just want to take a few moments to address some of those. And I do apologize to those who sent in a question that we will not be able to answer today, but I do encourage you to go back and visit the CurePSP YouTube channel. This is our 5th Ask the Doctor webinar, and the other 4 were led by Dr. Golby, and he covers a lot of questions about PSP, CBD, and MSA, really getting into the nitty-gritty with a lot of the symptomatic questions, questions about genetics, sleep, medication, so on and so forth. So that being said, I'm going to kick it off. This is a question that was submitted by Bill Hollinger. And the question is, why does the progression of PSP, the symptoms and deterioration vary so widely among patients?
So the short answer is we don't know for sure. And furthermore, the key projects for the NIH-funded research that I am leading at Johns Hopkins at the Atypical Parkinsonism Center is aimed precisely to answer this question, looking at different so-called variants or phenotypes of PSP. If you would like some conjecture, one idea is that, and this actually pertains to Parkinson's disease and arguably to the other atypical Parkinsonian disorders as well, is that we know there are different isoforms, types of tau protein behind PSP. And it's possible that different variants of PSP have different types, slight modification of the tau protein. What's even more complex, there's some preliminary evidence in Parkinson's disease, again from Johns Hopkins and other centers, is that in a given patient, the actual type of protein in Parkinson's disease, that's alpha-synuclein, changes over time. So there could be different modifications to the alpha-synuclein protein that influence its tendency to accumulate, to build up in cells, and to propagate across the central nervous system. We suspect that, at least to some extent, PSP, Parkinson's disease, and other atypical Parkinsonian disorders share mechanisms. And so therefore, this question about variability pertains outside of PSP as well. This is a very relevant question. I just want to highlight its importance because it has to do with what patients and families care about. It has to do with prognosis. And so just to give you an example, one of my main research studies concerns trying to predict, based on baseline MRI scan of a patient with PSP, what the progression will be at 12 months based on the standard PSP rating scale developed by Dr. Golby and quality of life questionnaires, cognitive testing. And we're looking at several PSP variants. We know that there are at least 6 variants according to the recently published PSP diagnostic criteria.
Excellent. Thank you so much. Let's move along here. This was a question that was actually submitted during the webinar today, but I thought that it was worthy to ask in our Q&A right now. Please distinguish therapeutic impact of passive, for example, listening and humming, versus active, singing and instrument playing, music involvement. And are there differences between instruments, for example, drums versus guitar versus singing?
Yes, wow, that's definitely a separate talk unto itself. The short answer, again, is not enough studies have been done directly comparing passive music listening versus active music intervention to say with certainty what the differences are. But if you're asking my opinion, and this is common sense, active music participation with live music as opposed to recorded music may have additional benefits. There are some suggestions of that. One study in particular that was published about a year ago looked at 30 patients with Parkinson's disease, 30 older healthy individuals, and 30 younger healthy individuals who are exposed to 2 conditions. Rhythmic, so listening to a song, row, row, row your boat. So it's kind of a variation of the rhythmic auditory stimulation paradigm that I was talking about earlier. And the other exposure in the study was having the patients sing to themselves, row, row, row your boat. So it was interesting, and this needs to be followed up in other studies, is that there was improvement across all 3 groups in terms of walking parameters, such as walking speed, for instance, regardless of whether they were listening to a recorded version of Row, Row, Row Your Boat or they were singing it themselves. But the greater improvement was when they sang it to themselves. And the greatest amount of improvement and I'll just, in decreasing order, it was Parkinson's disease patients, older healthy individuals, and even younger healthy individuals all had experienced greater improvement when singing to themselves as opposed to hearing it from outside. Now, again, I just want to underscore, this is not going to fit all, because if you take a patient with dementia, and I do hope that we could address that question that was asked about the differences between dementia and Alzheimer's, and also Parkinsonism and Parkinson's disease. That's a very common. So in patients with dementia, increasing their cognitive demand or load by having them sing while they walk may actually worsen things. So this is what I mean by one size not fitting all. The patients with Parkinson's disease who were participating in the study I'm talking about were generally early PD. So they clearly were well compensated from a cognitive perspective and able to sustain attention both on their walking and balance and on singing the song. But it's like the joke goes, some people have trouble walking and chewing gum at the same time. Walking and singing might be even more troublesome.
Sure. Well, thank you for bringing up, thank you for answering that. And then thank you for bringing up the other questions that we had discussed previous to this webinar. So let's talk about the relationship between Parkinson's and PSP.
Yes, absolutely. And I could be brief here. So as I mentioned in one of the introductory slides, when we talk about the term Parkinsonism, I know it's a kind of a long word, it refers to a combination of one of those four cardinal neurological examination features: tremor, rigidity, bradykinesia, which is slowness of movement, loss of fine motor control, and walking difficulty, balance issues. That's the postural instability. The most common cause of those symptoms, two or more of them, is Parkinson's disease. However, in the differential diagnosis, other causes that are less common for those symptoms and examination findings by neurologists are PSP, multiple system atrophy, dementia with Lewy bodies, and corticobasal syndrome. There are actually other causes that we group separately that are non-degenerative. For example, probably the most common would be stroke. The idea is vascular Parkinsonism. That's another separate diagnosis. Yet another one is normal pressure hydrocephalus, which is a separate discussion as well. But that's, in a nutshell, that's the distinction. If it's okay with you, just I would like to, sort of related in my mind, address this idea of dementia versus Alzheimer's, because it pertains to all of the disorders. So like Parkinsonism, this is a nice parallel, dementia is just a clinical description of a patient who tests significantly below the norm for their age and educational level on certain neuropsychological assessments. And in addition to that, that patient has to have at least one basic activity of daily living that they need help with because they are unable to carry it out because of cognitive memory difficulties, executive attentional difficulties. So you need that. That's the clinical construct to describe dementia. Again, kind of like most common cause of Parkinsonism is Parkinson's disease. Most common cause of dementia is Alzheimer's disease, but there's a differential diagnosis. And that includes Parkinson's disease dementia, PSP-related dementia, certainly dementia with Lewy bodies, and so on and so forth. We don't have time to talk in more detail, but I just want to make sure that we address that.
Great. Thank you so much.
Absolutely.
Let's talk about this. This was a question that was actually just shared in the webinar as well and mirrored one of the questions that came in via registration. I've tried to find a music therapist for a PSP patient in Rochester, New York, but to no avail. Is there a way to locate one who in this current pandemic environment would facilitate virtual sessions? Now I realize that that's a very specific locational question, but there's the question of how can people find this service and how can they get prescriptions to use music as medicine?
Yes, absolutely. So I'll be very brief and we could share this. www.musictherapy.org, the American Music Therapy Association, has a location finder. Before doing this webinar, I checked and they have 3 people/centers in the state of Maryland, for example. As you can imagine, there aren't enough music therapists to go around, so it well may be that there isn't somebody in Rochester, New York, but you'll find out if you go to musictherapy.org and search. I know for a fact that my colleague my colleagues at Annapolis Music Therapy Associates do provide this service virtually. A number of music therapists do. And you can just Google Annapolis Music Therapy Associates and go from there. So that is something that you could find readily.
Wonderful. Well, I believe that takes us to the end of our time that we have here today, and we sincerely appreciate you taking this time to be with us this afternoon. Thanks to everyone for submitting so many wonderful questions to today's webinar. If your question was not answered, again, I do encourage you to visit our CurePSP YouTube channel. A lot of the questions that were submitted have already been answered in previous webinars, and we are working on currently compiling the information that Dr. Bowlby shared in those webinars, and then subsequently the information that you shared in this webinar today, we will make that available as printed material as well and available on our website. So thank you, Dr. Penteliat, for taking time to speak with us today here on this platform, and to CurePSP for providing it to us. And thank you to Power Over Parkinson's for partnering with us on this event. Like all of our previous Ask the Doctor webinars, this video will be archived. So please check the website in the next few days and keep your eyes peeled to future communications. And please save the date. Thanks to you, Dr. Penteliat, for connecting us to Dr. Sonia Scholes. For everyone out there interested in joining us for our next webinar, please mark your calendars for Tuesday, September 22nd at 2 p.m. A link to register will be included in a follow-up email after this webinar is concluded. And these webinars are only made available because of the donations from viewers like you. So thank you so much to our generous donors and for you for being here with us and sharing your wonderful expertise and insight in this, on this topic.
My pleasure. Thank you for having me.
Thanks. Thank you, everyone, and we'll see you again soon.